Good evening, everybody, and welcome to the meeting. We won't do introductions at this time, but the speakers will introduce themselves as they come up this evening. And we have received some apologies tonight. Simon Morrick from York Teaching Hospital can't come, and neither can Lisa Winwood or her substitute, Phil Kane, from the North Yorkshire Police. Naomi Lonergan can't come, but I think that we have her substitute here, and he's very welcome. Mike Padgham, we think, might not be able to come from the Independent Care Group, and the other one is Steph Porter, and Steph Porter's had great trouble in logging on, so we're hoping that she will arrive with us, but we don't know. I'm sorry, David, I forgot your name. Oh, she's on the phone. Good. So David Kerr is here from TUV. So I think that's all of them. And I first need to know if anybody has a declaration of interest that isn't already on the list. No, no hands. Good, thank you. The minutes of the last meeting. Now, there are some amendments to the minutes. Tracy, would you be kind enough to go through them, please?
Oh, thank you, Chair. Yes, we've got one amendment and then just an update. So the suggested amendment is on item 40 in the minutes, and it falls under the first bullet point under the sentence "in response to questions from board members, it was noted." And it reads that the COVID-19 pandemic had caused a large increase in operation waiting times and that deconditioning would therefore be vital. It actually should read that the COVID-19 pandemic had caused a large increase in operation waiting times and that work around preventing or minimising deconditioning would therefore be vital. So that's just a point of clarity. Additionally, under item 40, the Ageing Well Partnership's progress report, there was a query as to whether the older people's survey should be revisited or repeated. And this was discussed at the June meeting of the Ageing Well Partnership, with the following response to be given to the Health and Wellbeing Board just to keep them updated. So the response was, the Ageing Well Partnership considered the option to carry out a follow-up to the older people's survey, and it was agreed that this would not be appropriate as all the actions from the survey have been aligned with the age-friendly action plan, and any follow-up survey questions are included within the age-friendly surveys. To carry out another older people's survey in addition would be a duplication. And also at the May meeting of the Health and Wellbeing Board, there was some concern expressed over the timeline for the last domain of the Age Friendly City project, and we discussed that at the Ageing Well Partnership as well, and it has been confirmed that flexibility has been built into that timeline. So, and just finally, one last brief update, that since the last meeting of the Health and Wellbeing Board, the chair of the Ageing Well Partnership has changed, and going forward it will be chaired by Joe McKayley, the Head of Communities from the City of York Council. Thank you.
Thank you, Tracy. Are there any objections, particularly to the amendments to the minutes, or are they acceptable to everyone? We're all quite happy. Okay, thank you very much. I just want to add one more thing before we go on to the first substantive item. Right at the end of the meeting under urgent business, Councillor Cuthbertson has got a brief point of information to raise, and I'm going to allow him to do it very briefly. It's only for noting, it's not for discussion, but it needs to be noted now. Right, so our first substantive item is the focus on health inequalities, and Peter Roderick is going to present us with some slides, and we're going to have a discussion about what he tells us. And this follows on from the workshop we held in April. So, Peter, you carry on with your presentation, and then will you lead the discussion to identify 2 or 3 strategic priorities and work streams to focus on. And we're asked to take into consideration the testimonies, Annex A, which I hope you've had time to read in the agenda pack. If you have priorities, it'd be useful to indicate timescales for any piece of work we identified. If there's a board sponsor, that will help. Right, Peter, all yours.
Thank you very much, Chair. If people possibly could confirm that they can see some slides, that would be really helpful. Wonderful. Thanks, everyone, and good evening. I'm Peter Roderick. I'm a joint consultant in public health, working between City of York Council and Vale of York CCG. And I have a few slides to introduce the paper. The workshop that we held in April was a closed workshop for board members to focus on health inequalities and the impact of COVID in our city and inequalities. And I think one of the aspects of this conversation to have here today is to bring what was a closed workshop in which we were able to break out into various rooms and to have smaller discussions into a public setting and to bring some of the things that we presented privately into that public setting, but then also to move the conversation on into thinking about the Health and Wellbeing Board's role in some of the work that we identified and how it best leads the inequalities agenda. So what I'm going to do in these slides is not replay the workshop, but just remind people what we discussed as it was over 2 months ago now, and just hopefully help refresh our memories on that, which will lead to some discussion as we go. And on these slides, you can see what would be one of probably many definitions of health inequalities, and there probably isn't only one single version of that truth, but we were working along a definition of health inequalities being avoidable and systematic differences in, I guess, perhaps two things: healthcare access and health outcomes. There are probably more than those two things, but those are two big ones, and those would be between different groups, which you could we could talk about income groups, you could talk about groups from different ethnic backgrounds or different cultural backgrounds, and many ways that health inequalities can be seen through society. And when we discussed this back in April, we did have some data that dug into that for York, and essentially the latest data that we really have on the inequalities perhaps that existed pre-pandemic as we went into this crisis period, but then some more recent data and some of the work from the Rapid Health Needs Assessment to help us understand some of the impact of COVID on the population over the last year. We also took some views from local organisations who are really on the front line of delivering services and asked them some very open questions, essentially about the health inequalities that they observe in the communities that they serve, and they submitted some testimonies to the board, which are included in today's paper pack. And then, as I say, we did have some breakout groups and open discussion on all of those issues. And not wanting to replay this, I have to hold myself back from putting a graph in every presentation I'm in, and so I've given myself one, which is this one. Deprivation is, of course, not the only way we can talk about inequality, and that's probably important to emphasise. However, deprivation often wraps up lots of other types of inequalities, and this is one of the starkest ways I think that you can talk about and understand inequality in York over the last decade. This shows for both males and females the differences in life expectancy and the changes in life expectancy over the last decade. If you were to divide York into 10 groups, where the 10th is the most deprived group, judged by a fairly sort of standard national index called the Index of Multiple Deprivation, and 1 is the least deprived. And three things we can observe here. First of all, over the decade, the gap got wider. So life expectancy gap increased between the richest and the poorest in York, in line with what we've seen elsewhere nationally. Second of all, a rise in life expectancy, which started, according to Michael Marmot, probably around about 1960, and continued until 2011-12, stopped. And that was seen nationally and is seen here as well. So life expectancy gains have essentially stalled. And then the third thing to notice about this is that the 10th decile, the most deprived, are an order of magnitude worse off when it comes to life expectancy. It doesn't go down neatly when it comes to that 10th decile. We have a bigger jump between 9 and 10 than we would do between 8 and 9, for instance. And again, that is seen nationally, and it's often called the inequality cliff edge, that those at the very bottom are quite a bit worse off when it comes to health outcomes. The testimonies that we received from the various services really dig into some of the reasons that might lie behind some of this. The Healthy Child Service, our school nurses and health visitors, talked about rises in perinatal mental health issues across the last year due to COVID and potential isolation of those who have newborns. The York Carers Centre talked about isolation, talked about impact on carers' breaks and respite of a pandemic and lockdown, talked about the impact of shielding. York Mind talked about poverty and the access to services when perhaps digital ability is not that high, but there is the expectation that you can just use a digital device to access things. Well, not everybody can. Changing Lives talked about people with multiple complex needs having often higher levels of exposure to direct COVID-19 infection and existing poor health beforehand, which will have got worse across the pandemic. York Older People's Assembly told us about isolation and loneliness, and also about reduced access to health and care services on non-COVID issues. And then York Travellers Trust told us about mental health in the travelling Gypsy and Roma communities, and talked about potential impacts which may have led to some really serious mental health events within that community. I want to be really clear that when we talk about inequalities, we are talking about a number of factors, and this is from some work that Chris Bentley did for the Department of Health and Public Health England a couple of years ago, which was published in the Health Inequalities Toolkit from Public Health England, which talks about 3 layers or 3 sets of causes. The layer that's marked C on this diagram is the attributable risk. So these are the things that often when we work in primary care or in the healthcare service, we try to modify. We try to bring people's blood pressure down because we know it prevents strokes. We try to bring anxiety and depression down through sort of low intense CBT therapies because we know that those things have a good evidence base for working. And that's all very important work. Those are the attributable risks generally for health inequalities because we find high levels of the green box in poorer communities. But if we go down to layer B, we talk about the causes of these things, and actually high blood pressure, well, we know that smoking, poor diet, lack of activity, all 3 of those things are contributory to higher blood pressure and hypertension as a diagnosis, and you could talk about many other factors. But of course, we can't get stuck even at layer B. We have to talk about the causes of the causes, and in the yellow and the red box, Chris Bentley and his team identified psychosocial risks, they called them, isolation and social support, social networks, self-esteem, high self-blame, low perceived power, loss of meaning and purpose in life, which can sometimes lead to some of the behavioural risks that we see. But those things are not evenly distributed across society, and what we see in the red box often are the conditions which create what we see in the yellow box: poverty, poor educational attainment, unemployment, discrimination are often the causes of the causes when it comes to what we see in everything else, and all of those things lead to either poor or good well-being and everything in between. And Chris Bentley also uses this diagram to show that if we're talking about measures that we want to put in place, we have to be realistic about how long it takes for them to work. So if we want to change a city such as York's performance when it comes to managing high blood pressure, we would actually probably see a payoff in deaths from stroke or cardiovascular events or new onset diabetes within 3 to 5 years if we were to, for instance, double the number of people diagnosed and managed with hypertension. If we want to see a payoff from tobacco, alcohol, obesity management type work, we would be talking about 8 to 10 years when we would really see that coming through to population level data. But if we want to talk about working on housing, poverty, work and skills, employment, we're talking about a 12 to 15 year time frame. I guess all that to illustrate is that this is the domain of long-term thinking when we talk about health inequalities, and that is potentially something I think that should shape our discussion, and certainly came out in the workshop. So finally, the workshop, this has got a lot of words on, but it is essentially what is in your paper. The workshop came up with some feedback on the gaps and challenges that board members felt troubled the most. some assets that we thought would help reduce inequalities, because as a system we've committed and we try at all times to try and be asset based and not simply think about deficits. And then how we protect the next generation, and a particular emphasis, I think, on what the evidence would say, that the first 1,001 days of any child's life, from moment of conception until broadly nearly 2 years of age, is the most modifiable time. So much of their health is set in that time period. And as you can see, board members came up with lots of things that we feel we need to do in these areas. Lots of work probably going on in each of these areas already in the city. But I guess the question is, how much more can we harness? How much more can we promote? And what would the board like to see happening? I won't read through everything that you see here, but as you can probably see, a lot of the things that we picked out in previous slides, the health of the traveller community, for instance, support for those with alcohol harm and dependence, delayed diagnosis around cancer, and then in terms of some of the assets, social prescribing is a huge asset, co-production, actually involving people in the work of producing healthcare services in terms of the assets, and then in terms of the next generation, the healthy food environment, understanding the impact of COVID on families and appropriate support. All of these things I hope would play into the conversation, and they're highlighted in the paper. I would highlight the Marmot framework just because
Pete's disappeared, and he said he might. Hopefully he'll be back with us in a second. We'll just give him a moment. Fancy cutting off Michael Marmot. That's a terrible thing to do.
Apologies, Chair. I'm back now. I wonder if you can hear and see me.
Good. Yes, we can.
Thank you. Apologies to everyone about that. Good thing I had a backup. So just to highlight the Marmot framework, discussing with the chair beforehand, we thought it was just always really helpful to bring this. This was from the original strategy in 2010, but Michael Marmot produced an update at the end of the decade. And these are the 5 areas that Marmot identified would produce that fairer and healthier society that he talked about, giving every child the best start in life, enabling children, young people and adults to maximise capabilities and have control over life, creating fair employment and good work, ensuring a healthy and standard of living for all, and creating and developing healthy and sustainable communities. And so we have a chance now to discuss. And rather than set of questions, which might set us into tram lines, I will hand back to you, Chair, really to guide that conversation. But for me, I think there is something about immediate actions that the board might wish to ask for, and to ask to be led by the various partnership groups we have in the city. There is something about building on the Marmot framework as we go forward. Are there areas that we feel York might be stronger or weaker on? And thinking about the board as the lead for inequalities, but not working on its own. And Tracy Wallace very helpfully has done this diagram you see on the screen, which maps all the different partnership groups gathered around the Health and Wellbeing Board and its strategy. And I guess this is just illustrative to say there's lots of partners working on bits of this. Do we feel as if, as a Health and Wellbeing Board, we know how we lead strategically? We won't be able to do everything. We won't be able to commission a set of 100 actions out of today. But what are the strategic levers that the board is able to pull and to push on, really, to get this conversation going? So, Chair, I will stop my sharing and I will hand back to you, and perhaps opening out for questions.
Yeah, thanks very much. Nigel, wherever you are, I'd like you to start, if you will, please, as Vice Chair, and just give me some thoughts or impressions.
Yeah, thanks. Thank you. And thanks, Peter, for that great presentation. Really summarises it very, very well. I think, as you'll all know, I feel this is a sort of a line in the sand for us to start again and start to review and refresh where we need to go to as a city. And I think looking at those A, Bs and Cs that you put in around the sort of the 5-year, the 10-year and the 15-year, I think for me, there's something about the long-term legacy of the first 1,000 days and getting that right. So for my mind, that's key. But then how do we also look at those medium and short-term bits? And I'm sure Emma, from primary care within within the city has some thoughts around the sort of shorter term bits. But for my mind, it's very much this is where we need to be. I was going to ask one question, which was, are there any cities out there that have done this? You know, what does good look like? And are there any cities worldwide that have embraced the Marmot principles, and could we learn from that? So that was just a sort of an open question as well, Chair.
Thank you. I'm going to ask Peter to reply, and then I've got 3 people waiting to speak: Sharon, Janet, and Sian. So, Peter, will you just respond to Nigel's question?
Well, Nigel, from my head, the classic example of a Marmot city is Coventry. A lot of cities embraced Marmot and worked it into their health and wellbeing strategy, but Coventry decided to adopt it as, I think, a whole council framework for the council, and a whole health and care system framework for looking at the ways in which they achieve better health and well-being. It was 10 years ago, so it would be actually very interesting to see what Coventry's healthy life and life expectancy trajectory has been since then. There are probably very good examples on each of the A, B, and C. So when it comes to the A, attributable risk, all of our hypertension standards in England are set using Canada as a best example. Canada managed to identify and treat 80% of its hypertensive population. And actually, if you just look at the number of lives that saves by stroke alone every year, it's incredible. And actually, we don't do particularly well as a country on that. And as a city, unfortunately, we don't do particularly well either at treating people with high blood pressure, or even identifying people as a proportion of what the research would suggest is our population. So there are definitely models out there, but it is probably a very good question about specifically the Marmot framework and how that leads to better health and well-being, and whether Coventry are the right city to choose. Sharon probably knows lots of other examples as well, I imagine.
Right, Sharon, you're next. If you just introduce yourself and then make any comments or questions.
Yes, I'm Sharon Stoltz, Director of Public Health. I would echo Peter's comments about Coventry is the city that has really held up as an exemplar in terms of how they've adopted Marmot. I've been in a number of different national events and heard the Director of Public Health and other colleagues from Coventry talk about what they've achieved. And so I'm sure, Chair, we would be able to arrange for some twinning with Coventry's Health and Wellbeing Board if this is something we'd be interested in pursuing. I just wanted to make a quick comment, really, because I'm very interested to hear what everyone else has to say. But Marmot has actually refreshed his framework following COVID and the pandemic, and has added another area of focus, which is climate change. So there are actually the 6 areas now with climate change being recognised really post-pandemic as one of the key issues we need to focus on. And obviously as a city, we're already doing work around that. That's all I wanted to say, Chair. Thank you.
That's very helpful. Thank you. I've got Emma and Ian in the queue, but Janet is next.
Done it. Thank you very much, Chair. And it's in a sense, it's with mixed feelings I'm back on Health and Wellbeing Board. I go back so far, I was on the very first Health and Wellbeing Board that York set up. God, quite when, I'm not sure, the 1990s? No, 2000 probably. Anyway, I was there. The first thing I have to say is what depresses me is that this report, it could have been written 5 years ago, it could have been written 10 years ago, and some of the detail may be slightly adjusted, but quite frankly, the broad thrust of it is identical to some of those reports we received way back when we were a very new, very excited Health and Wellbeing Board, and we were going to change the world. And it's very sad, in a sense, to come back after 2 or 3 years gap to find we haven't quite changed the world. But I live in hope. And what I feel we need to do, in the sense, because we've been in this place more than once, and I suspect there've been reports coming to Health and Wellbeing Board that I will have missed over the years. But because we've been in this place, I think we've got to really, in a sense, give ourselves a wake-up call and say, let's do something completely different from what we have ever done before. I think we have always, I won't say tinkered or fiddled, but we've always, in a sense, focused on some of the, I suspect, some of those top line things, the things that are the quickest to sort out, and the quickest perhaps to bring a result. Whether they have or haven't, I leave it to others to say. So I want to do, and I'm sure Councillor Runciman will be with me all the way, because both of us have started our political lives at the other end of the scale with the children and that agenda. I want to say, I always have said, start at the beginning. You absolutely need to start at the beginning. If we can get it right for the children that are being born now,
Yes.
and the children that are still at that very early development stage, then we will be doing more for this city than anything else we can do. So I am absolutely passionate about the 1001. I'm passionate about Marmot. God, I went to the very original presentation when I don't know whether he actually came, but we had a presentation from him about his very first report, and it was inspirational, absolutely inspirational. Yes. I'm just fed up. We haven't really seemed to have got very far. So it'd be lovely to find out how Coventry have developed. But I want to say, I always say, let's start at the beginning and let's see if we can start to put some things in a good place for that new generation that will be York's life when, well, me, thank goodness, will be certainly pushing up the daisies. But it's been fascinating, slightly depressing, but let's be positive and look forward.
Thank you, Janet. Yes, I heard Professor Marmot give an update recently. It was a webinar, and he's still as passionate as ever he was, I would say. Not only that, but he's right. So my next speaker is Sean.
I suspect this won't be a surprise to anyone, but actually I think one of the key things that we have failed to do in the city, but all talk about quite a lot, is co-production, and actually making sure we're genuinely listening to people in York and helping them help us deliver the changes that are needed. So I am actually putting myself forward as a sponsor of some work to support developing new systems, new ways of doing that, new networks. I am very, very grateful to Nicola Greenwood at York Hospital, York and Scarborough Hospital, I should say, who has volunteered herself to work in partnership with us at Healthwatch York to create a voice and lived experience collaborative. And what we want to do is also encourage partners here to think about what routes and networks and systems we might bring into that. So I'm thinking about chairs of patient participation groups. I'm thinking about a whole list of people that I'm not going to go into right now. But I believe if we create something like that, where we guarantee we're going to bring information to that, we're going to share things, we're going to discuss things, and we're going to genuinely listen to what people want and build those new things with them, we could have a fundamental change to how people engage with our health and care system. If we design our system together, it belongs to us, we become passionate about it, and we believe we can change it. So that's my offer. I think there are some other big ideas we need to talk about. I think reflecting on Councillor Looker, what can we do differently, what needs to change? There are huge issues for me around culture and whether we believe collectively that we have a a joined up shared vision that is embedded throughout everything we do. So I'm thinking, you know, if you're talking about Coventry and you said they have a one council approach to health and well-being, are we confident that the work we are doing around planning, transport, work, the environment is based around a shared vision of what really good would look like in terms of health and well-being for our population? I'm not volunteering to lead on that, but I think there may be people on the call who can give a very good lead on that and sponsor that through. I also think one of the things that comes up time and time again is around, are we using everything we have to enable people to get into employment and retain employment? And the gap between that in terms of health and well-being outcomes for people who retain employment, it's massive. And again, I don't think I'm the right person to lead that, but I do think we collectively need to be thinking about that. And if we did go for a one council approach to health and well-being, that is something that I think needs to be on our agenda together. So I think that's everything I wanted to say. I will be quiet now.
Thank you, Sian, and thank you for the interesting comments about co-production. Really, really important. The trouble is that with all these things, you know, these are all related to each other, and we saw that in Tracy's rather clever diagram. And you can't split one off. You can't split employment off from health, from well-being. They're all part of it, aren't they? Right, Alison, you're next.
I'm really glad I've gone after Sian, because she said most of what I was going to say, because we did have a discussion at York CVS earlier. So thank you, Sian. The one thing, I mean, we recognise that there is such a lot going on already on all of those issues, practically, that Peter mentioned. There are work streams, and I'm involved in most of them, quite frankly, so I'm not offering to lead on anything else. But one of the areas that keeps coming up time and again for us at York CVS from the people we talk to is about lack of face-to-face access to primary care, which is exacerbating health inequalities. So there's no criticism at all to our primary care colleagues, because I absolutely understand the challenges that you have, but we have to recognise it's a challenge and perhaps think about what we can do to ensure people don't fall further behind because they can't get to see a GP face-to-face. So and Emma, you're going next, so you might want to respond to that, but that's just something that hasn't been highlighted. Yeah, so no criticism, it's an issue that we do come up against regularly.
Yeah, it's certainly been raised with me. Emma's just the right person to make a comment on that or say what she really wanted to say in the first place. Emma, it's you.
Thank you, Chair. Yeah, I'll try and come on to that towards the end, if you may. So I guess what I would probably like to reflect first is Michael Marmot's report tells us that the wider determinants of health have more impact than me as a healthcare professional. Sorry, forgive myself. I'm Emma Broughton, I'm a GP in York, and I'm head chair of the Care Collaborative. So, but the wider determinants of health have more impact than I, as a single doctor working in the system, could ever have. So a child growing up without poverty, having education, all of these things make more impact than any health intervention. However, it's accountable. So I guess there's a couple of things I'm going to welcome. So I want to have a bit of a balanced approach to this. So the wider determinants have more impact. However, I think one of my pleas is that health, so I'm going to say this, the primary care profession, but all healthcare and patients need to work in collaboration. And I think one of the biggest things we're finding at the moment is there is a media storm where sensation over information is being shared. So I will come on to the GP appointment element, but I would say on the whole, it's more sensational to say negative things than to try and get the positive information and some of the good that is happening, because I think actually York is a great place to work and a great place to live, and we have a lot to celebrate. So I guess one of my asks is, in that kind of vein of the public health, help us to help you, we need to change the language. So, you know, wanting to see a GP and needing to see a GP are different languages, and I will come on to that towards the end, that I think we have actually moved to a slightly more clinical based model, which is actually better, and I'll come on to why I think so in a second. But I think that working together and in partnership, so that's working with Healthwatch, it's working with patient participation groups, targeting the vulnerable in our society, which actually is more about clinical need than want, unfortunately, because our most vulnerable don't access our care, and how do we change our framework? I would like to welcome, before the pandemic, there was a massive shift for community care. There was a new contract, the primary care contract, called a PCN contract, that was, for the first time, actually had a focus on population health outcomes. And for us, that was a real change in ways of thinking. And I think we really have tried to embrace that. So before, it was all about achieving a target. It's easy to get 60 or 80% of your diabetics checked if you ignore the 20% who are the highest risk. And I think there's been a real change in our shift to actually starting to now deep dive and look at those who don't access healthcare and changing how we approach things. So I think really good things were happening up to the point where the pandemic hit. And I think we have to give ourselves a moment for breathing space here. The pandemic has had such a massive impact on the health and well-being of our community. And actually, we were in a very positive place before the pandemic. We were close to eradication of child poverty. So many good things were happening. And obviously York was in a position we probably had broader shoulders than others, but it has nevertheless had an impact. But I think we're doing a lot of good things now to try and get ourselves back on track. Health has gone through, certainly community health has gone through a massive I'm going to phrase this carefully, but we have a better digital access. We are able to help more than we've ever helped before in different ways. Have we got it 100% right? Certainly not. Have we got more to do? Of course. Do we need to work on vulnerable groups? Absolutely. But actually, if you speak to every primary care organisation, we're actually offering more primary care contacts than we offered this time pre-pandemic, in spite of a workforce that has been devastated with self-isolation, has dealt with, so many additional asks of us. I actually think there's a lot to celebrate here, but I do appreciate, have we got it right for everybody? No, there is more we can do. So I guess my key messages here are about working together and in partnership, taking more ownership with our population, giving good information rather than press sensational headlines. I think just to come on to my role, so in York Healthcare Collaborative, I would say nearly all of the areas Peter has discussed there are on our radar, on our agenda. And what we're trying to do, to come to Sian's point, is collaborate against the various providers in our York system and take that asset-based approach. So learning disabilities is high up on both the Alliance and the York Healthcare Collaborative's agenda, because we know that's where one of our biggest health inequalities lie. And we've got active workshops. We're doing a big workshop on end-of-life care. We've got a lot of targets that I'll come on to my later report, trying to address some of those health inequalities. So I want to say that I think York's in some respects in a much better place than it was pre-pandemic. We've got York community and primary care working as one, all signed up to a single provider body, which is something that has never happened before. I think we're working and we're focused on health outcomes in a way we never have been before. So I think I'm trying to put a positive position on here. I know I do hear that. I can't see my GP face to face, but the access is there, and I think things are better than they were. Thank you.
Thanks, Emma. And I'm sure Alison will speak to you outside the meeting if she needs a bit more information or advice. I'm going to take Ian, then Denise, then Sian. Then I'm going to ask Peter and Sharon if they'd like to come back in and make some comments on what they've heard. Ian, you're next.
Yeah, thank you. Councillor Ian Cuthbertson, I'm the lead member for Children's Services. I take the same line as Janet Looker. Haven't been involved with it quite so long, but it seems to me it's not just a question of starting at the beginning. I take the Yorkshireman's view of a gram of prevention is worth a kilo of cure. And I think the comments that we used to hear about the National Health Service being actually the National Ill Health Service still have a grain of truth about them. But nevertheless, I think that starting early is the right thing to do. Helping parents to deal with a pregnancy before it happens in the most favourable way would be really good. Helping them to avoid alcohol, tobacco, narcotics for 6 months before a pregnancy takes place. I know it's pipe dreams, but it's a possibility. And then that first 1,000 days, including the days of pregnancy, well, I'd like it to be extended a little more, but that's the crucial time to get the best behaviours. We humans are creatures of habit. Get those habits embedded early. Get child talking to mum and dad and mum talking to child. So often we hear of parents who spend all their time on their mobile phones or looking at the telly, or they put the child in front of the telly. Those are the kind of things that we can deal with very relatively cheaply, dare I use that word, and they're habits that stay with us throughout our growth years. And then, you know, all the other things that we can do. When I say teaching children to talk, there's a project that we're trying to get going in York, which has had some limited success already. We'd like to wheel that out across the city, and that is surely going to be good. But things like health education, health care for children, and getting them to have an early start in life, that's really got to be for the good. The other thing is that I think that these really later adulthood diseases, diabetes, I declare an interest. I'm a late onset type 2 diabetic, but guess what? I caught it early enough to control it by diet. So I'm not costing anybody anything apart from a check on my HbA1c level every so many months. And that's, I suppose, the minimum that you can cost apart from nothing at all. Strokes, what's the critical age at which, you know, the onset of a stroke can be identified? It might be 0 years, it might be perhaps in the 30s or the 40s. So at what point do you need to introduce healthy exercise and diet and make sure that as an adult we include those in our activities, so as to ensure, or to help ensure, that we have a late age that's not so prevalent. What's the word I'm looking for? Prone to these conditions. I'll leave it at that, but you get my drift. And Janet, I agree with you.
Thank you, Ian. The next speaker is Denise.
Thank you, Chair. Yes, I think I've got 3 comments to just touch on quickly. I suppose the first one is pretty self-evident to everyone here, but I'm sorry to say it anyway. It seems to me that if we are looking at what actual actions we pick up and focus on, as the original question, are we going to pick out 3 or 4 particular areas of focus following this discussion? They obviously do need to be areas where the Health and Wellbeing Board offers the most kind of added value, rather than duplicate something that's happening already. And I'm not going to try to say what I think those are just now, because I think obviously people know a lot more about that than I do. But I do think, I suppose, actually, that takes me really to I'll make that my second point, that sort of question that people seem to have touched on about the long term and short term and the immediate, which I think Peter also touched on in his presentation. You know, you cannot but agree that early intervention and children's reaching children when they're very early and supporting them has to be really important, and it has long-term effects. And I'm all in favour of the long term as well. It's good that we do policies that are for the long term, but obviously there are things that may need attention now, such as, you know, substance abuse seems to be something from the list you provided that perhaps, you know, a lot of things are being done on that, but is that one where we could bring added value by giving that a focus? I don't know. I think another one in the list was the health of the Gypsy, Roma and Traveller community, and that's quite a specific, but it is something that I think it would be really good if we could have some focus on. I know Peter himself has been participating in a group that I've been part of, along with Councillor Smalley, to refresh our strategic approach to supporting the Gypsy, Roma and Traveller community. So I think you know, bringing that, not just public health, but support from the wider health system to that would be a really positive thing to do, because there are an awful lot of needs there, as we've heard and seen it mentioned in the paper. And so my final one, I suppose, is just to pick up on what Sharon said about Marmot adding climate change to his list of key issues, and in terms of equalities, and I do think that's really important, both for the potential impacts that climate change can have in a way that often isn't equal, but also in terms of potential solutions, and all the co-benefits of what we may do to improve health that will also tackle climate change. So, you know, if we improve, have better air quality, we have more active travel, we help to tackle healthy weight and obesity, have healthier homes, we have lower energy bills, all of that agenda. I think it is really important aspects. I know, for example, we've put in an application to that brings together social prescribing with active travel, which I think is an excellent initiative as an example. And I would urge everyone here to kind of participate from their own organisations in the current consultation that we have underway on developing a climate change strategy for the whole city, and that this you know may sit within that in some ways.
Good. Thank you very much, Denise. And I think the final speaker, just for the moment, there will be more time for speakers, is Sian, before I ask for comments from Peter and Sharon.
Thanks, Carol. I just wanted to come in again about the access. I am very aware that there are a lot of sensitivities around this, and some of the information that's played out in the media has been less than helpful. I am aware that we are actually delivering more appointments in primary care than before the pandemic, but demand is outstripping supply because there are so many people desperate to see a GP. I think for me, there is something that we can do in Healthwatch. We are pulling together a snapshot report just to indicate what we have heard, where there are particular indications around health inequalities. We're working with a number of partners in the voluntary sector. So some of the people actually that we asked about health inequalities here, we've had some feedback from York Mind, from York Carers Centre, and from Community Voices around access for disabled people, for carers, and for people experiencing mental ill health. So I think what we want to do is just pull that together as a very quick report. It's not going to be one of our 975-page ones, you'll be pleased to hear, but I think there is something about health inequalities there that we should be tapping into. And I think there are people telling us what brilliant service they've had, but these tend to be people who are very capable of using the digital routes to access healthcare, and some of them have never had it better. So I think it's really important to share that message and to say that we totally understand that this report needs to be done in a sensitive manner to reflect the pressures on primary care and the challenges that we hear from patients. And so those two things will be balanced within how we put that forward. But I think it is something that we collectively could revisit and look at how we could help address some of those inequalities.
Thank you. Peter, would you like to comment on what you've heard so far?
Thank you, Chair. I'd say two things. Firstly, on primary care, I think COVID was just such a devastating virus, not just the nearly 400 people dead in a city, not just 15,000 cases. What we're getting here in the primary care situation is the impact of the pent-up demand of people who didn't see their GP, the impact of COVID and lockdown on people's mental health, on their eating habits, on the management of their long-term conditions. And you're seeing as well in primary care such an impact on staff capacity and the resilience of the average general practice, which are quite often not large organisations with small staff base, and actually the impact of just one single infection, which can go through a staff base and knock out through isolation key services, and there's something therefore about resilience there. I guess that does offer a glimmer of hope, not immediately, but a glimmer of hope that actually some of that pent-up demand that happened across the course of COVID will eventually play out, and those people will be seen, which doesn't probably help them right here and now, but it does potentially demonstrate or suggest that this is a particular issue that we have right now within the system that won't necessarily be with us forever. But Sian's absolutely right. It then challenges us all over again to say, well, if there are new health inequalities that a year or two ago simply weren't really around because most primary care was delivered through a 10-minute face-to-face consultation, we're going to have to change models and paradigms at the same time that very tired staff are just struggling to keep
practices going. So it's a really wicked issue, and I think being in it all together as a system and supporting primary care colleagues and actually having that sense of one team for York will be the only way we actually get through it. Then Chair, just another thing, which is just the obvious, that we've all almost talked about the first 1,001 days, and it feels therefore that should probably be factored into the board's thinking as it thinks about future health and wellbeing board strategies and it thinks about the work going forward. I would sort of reflect on public health work that we do around 3, I guess, substances which often lead to disease. So smoke, alcohol, and unhealthy food, and how all of those things are very much present in the first 1,001 days in one way or another as factors causing, if not direct disease for a child and for a child in the womb, but potential harm. I don't think we think about family enough when it comes to many of those factors. I don't think we help people who are struggling with the amount of alcohol that they are consuming in the family context enough. I think they possibly reduce the amount of alcohol they consume, then go back home and their partner may drink a similar amount and they're back up to previous drinking levels. I think there's something about the whole family approach. Smoking and smoking in houses is very much the case. And then with alcohol as well, there's the trauma aspect of it. And part of the first 1,001 days is that it isn't just the first 1,001 days. It is then being able to help adults as they grow who may have been affected by what happened in that early years with the trauma that they've experienced, and having trauma-informed ways of practice across the whole workforce, so we can understand when people are so badly affected by what has happened in early life. And I would just finally note that often this comes down to the money, and actually if you look at what the OECD average is for spending on primary care and prevention across healthcare systems, it's nearly 15%, but generally about 10 to 12% on primary care services and 3% or so on prevention. And in York is very reflective of what happens nationally. It's less than 10%. So we have that gap, not just on prevention, but on primary care too, the first line in a way. We spend more on acute and we get more acute problems. And there is something, I think, about the board leading that conversation as well, about where we allocate the finite amount of money that we have as a system. And that is, going to lead to the outcomes that we put in place.
Yes, that's very true. Thank you, Peter, and Sharon is next, please.
Oh, I'm just wondering how controversial I can be, Chair. But if board members will forgive me, I'm going to act as devil's advocate here a little bit. I would say that this isn't about the Health and Wellbeing Board adding value to the work that's already happening. The Health and Wellbeing Board is a statutory body. It was established as part of the Health and Social Care Act in 2012 to act as the strategic body accountable for improving the health of a local population and tackling health inequalities. And its statutory duties for developing a strategy and a joint strategic needs assessment, a pharmaceutical needs assessment, which are statutory functions of the board, represent that duty. My view is that the pandemic absolutely gives us an opportunity to reset ourselves as a board, to act as that system-wide leader. And actually, the Health and Wellbeing Board should be driving what's in the economic strategy, what's in the climate change strategy, what is in all of these other strategies, and holding them to account for how those strategies are therefore going to improve health and tackle health inequalities across York. So we need to turn the Health and Wellbeing Board on its head, so that we can, review our terms of reference, change the way that we function as a board and take that strategic leadership role. To underpin that then, I really liked the idea that came forward from the workshop about having a 20-year health inequalities strategy for the city, because that's how long we would need to, the time period we would need for a strategy. But that within that, we actually set ourselves targets so that we can monitor progress to tackle those health inequalities over that timescale. Coventry, and I think one of the reasons why Marmot has worked very well there, it's not a strategy for the council, it's a strategy for the whole city. The whole city has adopted the Marmot framework as a way of really trying to get underneath deep-rooted inequalities, those causes of the causes that Peter was talking about. So I that's what I believe we need to do. We can focus on alcohol, smoking, all of those issues. There is work already happening on those.
Yes.
But if we focus on the symptoms of inequalities rather than the root causes, as picking up Councillor Looker's point, we could be sitting here in 5 years, 10 years, having exactly the same conversation we're having now, not having made any difference at all. And then my final point about the best start in life, that's the first priority in the Marmot framework, giving every child the best start in life, which I would agree with Councillor Cuthbertson is preconception. So it is longer than the 1,001 days from conception to age 2, because what happens at the point of conception is really important. So, you know, preconceptual care, and in working with our families and, you know, prospective parents, that they're as healthy as possible. That includes maternity services, which is something we've never discussed as a health and wellbeing board. We don't have anyone here from York Hospital Trust today, which is our maternity services provider. But, you know, maternity services needs to be central to that. So I absolutely, you know, support the outcomes of the workshop. We've had a great discussion here. But if we really want to put our money where our mouth is, it's about getting that strategy in place, which should then drive investment across the whole of the city and get all partners, businesses, schools, universities, employers, the council, NHS, voluntary sector, everybody working towards the same strategic vision. And I'll stop there, Chair, otherwise I can talk all night about this.
We haven't got all night. No, I think that's very interesting, Sharon. And I think you have a point when you say this is the moment for a reset, because the pandemic has affected services that are being delivered across the city in very fundamental ways. And this is a good opportunity to think again. We've seen it in so many aspects of healthcare, including GP access, which has come up obviously tonight. Now, I'll take a few more comments before we start prioritising. And I think fairly obviously, the first 1,001 days plus is going to be one of our priorities. And I'm going to move Councillor Cuthbertson's urgent business up because it's actually very relevant to this item. But we'll take some comments first. Councillor Looker.
I was going to add that in some ways, Chair, we are being faced with an extraordinary opportunity for a reset in that, obviously, in total response to your recent plea for a letter to the Prime Minister, we are poised, are we not, to try and get some sort of statement around the future for social care. which we confidently expect will also pick up some of the way in which we work across the health and social care sectors. And as well as that, we are also confronting what has already been put in place, the reform of, or the change, I don't know which number it is now, I lose track of how the health service functions. So we are losing our CCGs, as we lost our primary care trusts, as we lost our health authorities, and gaining a whole new world. So in some ways, this is the absolute optimum time to revisit. And I love the thought of becoming not just a council and a health service, but a city that embraces this sort of vision, because I think it could underpin so much of the work we are going to be doing as York confronts a very, very new future for itself. So, Chair, I absolutely agree with Sharon. I think this is an opportunity for us to be bloody bold and resolute, as I think Macbeth once said.
That's fine. Yes, I know what you mean. I think we'll leave out the bloody. Anybody else want to comment before I start pulling this together? No hands. Okay. So I've got a lot of things written down that people have said, but one of the things that's been said the most frequently is about the 1001 days. And in fact, Nigel started off with that right at the beginning. And it's quite clear that everybody thinks that that is a priority. And those of us that have been coming to the Health and Wellbeing Board for some time will be very aware that we've had nothing on the agenda about children. And Councillor Cuthberts and I have been doing a bit of delving into this, and he is just going to talk to you a little bit about what we found.
Okay, thank you, Chair. Can everybody hear me okay? Yep, fine. If you look on page 189 of your agenda papers, or if you look back at, I think it was the last but one of Peter's slides, you will have seen in the slide in Tracy's very pretty diagram, which is, I now think is a pentafoil rather than a trefoil, as the guides would have had, that 5-leafed flower. In the bottom left-hand one, I think it is, there is something called the Euro K-board. That's also mentioned in the structure chart of your agenda pack on page 189. Now, the last time that the Euro K-board was due to meet was on the 17th of March 2020, and it was cancelled because of people having to prepare for the impending lockdown and everything that ensued. And since that point, York's Children and Young People's Safeguarding Partnership has been restructured, and there was a slightly more pressing need for that. So there's a bit of a question about the future of the Euro K-board, but the Safeguarding of Children's Partnership, it was actually more important because of the significance of that work to reorganise it. So the impact of COVID has then brought a focus on how that former Euro K-board, which was a subgroup of the Health and Wellbeing Board, as you'll see from that slide in the structure chart, how it can report to the Health and Wellbeing Board. So we have tentatively, I think tentatively, fairly finally tentatively, agreed to restart the board as a sort of a son of Euro K or a daughter of Euro K, with a broadly similar membership, and with similar objectives, but with a more formal reporting line to the Health and Wellbeing Board. So this body will receive minutes and reports from that board. And that board has got quite a wide range of preoccupations in terms of children's health, wellbeing, education, in terms of special needs, physical disabilities, everything else that we think of when we use the word children. And what we're planning to do is to contact the organisations who are involved with this organisation, this body, and the other organisations who were in the Health and Wellbeing Board, So, I mean, Healthwatch, you're in, TUV, you're in, but people like York College and the NSPCC and Danesgate and CAMS, who I think CAMS might have been here today. So that kind of external grouping, we want to get that body going again with that sort of membership. It won't necessarily be of 25 or 30 people each time. It may turn out to be a smaller meeting when people who are actually interested and involved in the agenda items attend. And we may or may not deal with meetings remotely, but we will certainly, we think, try to get it going ahead. So be prepared for your organisation to hear about a workshop that we're planning to run as soon as we possibly can. It may not be until late September, but that's the idea. So I hope that meets with people's approval, and any thoughts will be welcome at this point. Thank you.
Yes, I think it's important that that happens. It's important that that board takes note of some of the things that have been said today, and it's important that it reports back to the Health and Wellbeing Board. Very clear that it's almost top priority for everybody here. Sharon wants to say something, and so does Emma.
Yes, just very quickly, Chair, to add to what Councillor Cuthbertson has said, the leadership or the secretariat for that new group for children will sit in public health. I think in recognition of the fact that that group needs to look at a number of issues that we've already discussed this evening. So Children's Services, Amanda will take the leadership role for the Safeguarding Children's Partnership. And as DPH, I'll be working very closely with Councillor Cuthbertson and that group so that we can really develop it as a partnership that will really be focused on that long-term future for our children and young people, that will pick up on maternity services and the 1001 days as well. So I certainly welcome Councillor Cuthbertson's update, and I think with both of us on the Health and Wellbeing Board, there'll be an opportunity to make sure the board is better sighted on children's issues going forward.
Yeah, I'm comforted by that. For me, as Councillor Looker well knows, I had a background in early years, and it saddens me that we haven't had any reports about early years recently, so I shall look forward to them coming. Sian and then Emma.
Sorry, I think I've snuck in. I think Emma was first, but I did just want to pick up on that point around the first 1001 days. I do think parents of children born during the pandemic have had an absolutely unbelievably hard time, and for some of them, luckily, they've got nothing to compare it with, but I imagine that hasn't actually been much comfort to them. So I do think as a board, we also need to be mindful of the impact on parents. If it takes a village and you're not allowed to see the village, it's not surprising. Quite a lot of parents are currently very, very tired. So I think I would be very welcoming of any initiatives that we have to support those parents to start rebuilding connections now that that feels like it's possible. And I guess we also have to think about, for those parents who that isn't still an option, for whom Freedom Day was anything but, how do we keep building connections to those individuals to help them start to feel connected when, it's been a life-changing time in more ways than one for those individuals.
Emma's going to be the last comment, and then I'm going to summarise.
Yes, thank you, Chair. Just with regards to obviously having this focus on children, I say couldn't be more welcome from primary care. I think one of the greatest pressures we are experiencing as children's, both mental health, but actually behavioural problems. The impact of this pandemic, whilst the children haven't been the ones who've died, they have been severely affected by the mental health, the domestic violence rates. So the rates at the moment of very distressed families that we're seeing in primary care is rising by the day. It's becoming a common finding, and the impact is not on the child, it's on the entire family. A behavioural problem in a child affects both parents. It's devastating the impact, and it's something that's very real, and we're seeing it on the ground right now. There is a saddening, obviously, lack of support for this because it hasn't been anything like this sort of level. So I hope that can feed back into the report and into the work that's happening in this, because right now that behavioural support could not be more needed. It will become mental health support if the behavioural support isn't there for the parents who are struggling. So yeah, very welcome from our end.
Yeah, good. Now we've got two clear priorities at the moment and then some options. The first clear priority is the first 1,001 days, and we've just heard through Ian and Sharon how we're going to take some of that forward. The second one is Sian's, which is co-production and listening. Really couldn't be more important, I'm afraid, but we do have a lot of other choices. Would anybody like to suggest either a third or a fourth, and we can think where they sit? Some of them obviously sit elsewhere anyway, and some of them don't. So could I have a couple of suggestions? Nigel.
I'm going to come in a bit left field on Sharon's suggestion around how we reposition the Health and Wellbeing Board's complete situation within the system. So actually, is that the biggest thing that we could do? I'm just trying to think that how are we viewed within the City of York, and if we think that the best, what is our purpose as a city, what is our purpose as the Health and Wellbeing Board? Do we need to reposition ourselves? Should that be one of our priorities to really drive this agenda forward?
Yes, I certainly think it should. And I'll come to Sharon in just a moment. I think we are supposed to be strategic leaders across the piece, and we need to set a strategy and make sure something happens. And that is what we now need to look at to see if we need to reposition that. Sharon?
Yes, I would support.
Is it an old hand?
I would support that, Chair, because we don't have to just think about repositioning the board within York. It's also the role we want the board to play in the new health system. The Health and Wellbeing Board is going to have to develop really good relationships with the Humber Coast and Vale ICS. We need to be, York needs to be speaking as one voice, as one system within the ICS. And, you know, we've got other groups. We've got a report from the Health and Care Alliance shortly. We have a report from the Health and Care Collaborative. They have important functions to play. But to me, they should be driven by this board setting the strategic direction, determining what the priorities are and driving that through those two partnerships that we've got that are also part of the ICS system. So I would agree with Nigel that repositioning the board to me is the highest priority, and then having the 20-year strategy is also a key priority, because other things will flow from that if we get those right. And then, you know, absolutely support that idea of giving every child the best start in life. You know, that is key, isn't it, to the future of the whole of the city?
Yes. And it's been missing. I'm not going to let this item go on any further, I'm afraid, because we're now running over time. Sharon, will you and Nigel and I talk about that and then discuss how best to take it forward with everybody else? Is that okay?
Yeah, happy to do that.
Fine. Right, good. Before we go any further, I hadn't announced at the beginning that there was no public participation, and I should have reminded you. I think if the public had known how interesting our discussion was, they might well have come. But if anybody listening wishes to come and participate before the meeting starts next time, they will be extremely welcome. Now we're going on to agenda item 5, which is an update for the York Health and Care Alliance. And Peter or Sharon, are you giving a summary of the report here?
I'll hand straight over to Peter, Chair, if that's okay.
Yes,
Thanks.
that's fine.
Can I just confirm people can see me and hear me? This is now
Just.
Okay, I'll come a bit closer. This is now the third device I've joined this meeting on, and I do apologise.
You're very misty, but you are visible and very audible. Yeah.
Okay,
Go
fantastic. So very, very briefly then, this is an update report on the work of the Health and Care Alliance, and it also gives some summary of the NHS reforms that are currently happening. Significant degrees of uncertainty, but some additional certainty from when this was last discussed by the Health and Wellbeing Board. It lays out 2 key documents: the Health and Care Bill, which is currently being put to Parliament, and the ICS, the Integrated Care System Design Framework, how our regional body, which is Humber Coast and Vale, covering about 1.7 million people regionally, will structure itself, and how it will relate to the place, which is York, which we're obviously all concerned with, but in the NHS terminology, York is a place, and the CCG will no longer exist after next April, but there will be a large number of functions that happen at place level, and a lot of work going on at the moment to determine how that works. The Alliance has therefore been established and is meeting for its 4th time next week, and is trying to figure all of that out, really responding to what is happening nationally with the changes, the new legislation, and trying to understand how it will take on some of the place functions that the ICS are looking to delegate. And actually significant amounts of what will happen will still happen locally. And there is a level of ambition to say that York needs to be in charge of decisions that are made about healthcare, and be able to create an integrated system locally, and how we best do that. Well, that's the task that the Alliance have really set themselves. The paper talks a little bit about some of the topics the Alliance has covered, and also alongside the paper are the minutes of Alliance meetings that have happened so far. This is principally because the Alliance is a subgroup of the Health and Wellbeing Board, and we are bringing these minutes to this open meeting in order to make sure that they're accessible to the public and discussions can be seen for what has been discussed. So that's what the paper outlines, and I'm happy to take any questions on that. Lots of people who are working on York Health and Care Alliance, not just me, but I'm happy to take any questions that I am able to answer or we can take back in terms of the work of the Alliance. And I think the intention is for regular updates like this to come before the Health and Wellbeing Board, so that strong relationship can be forged. Thanks, Chair.
Thank you. Yes, we have to note this report and receive the minutes. But are there any comments or questions from anyone before we do? No? So we're quite happy to accept them. I found them very interesting, I have to say. They were just giving me a flavour of what was going on, which is exactly what I wanted. So I found that extremely useful. So thank you, Peter, for bringing them to us.
Thanks, Jen.
Right, agenda item 6 is a verbal update, I think, from Sharon, isn't it? Is that right, about COVID?
Yeah, there's a presentation, Chair, which I will rip through because I'm conscious of time. And thank you to Lawrence, I think it is, who's going to help me with the slide presentation. So I'm going to do a Chris Whitty and say, can I have the next slide, please? So really, this slide will be familiar to many of you. It kind of shows what's been happening with our case numbers throughout the pandemic. So as you can see, York is actually in our 4th wave. People talk about the 3rd wave. We had a small peak of COVID infection last spring. We have to remember that very little testing was happening at that time, so that this graph may not be fully representative of the number of COVID cases we had at that time. We then had a second peak, which was round about September, October time last year. We had another spike in January, February, got COVID numbers down very low for a period of time, but as you can see, the numbers have since increased. York, for a while, was above the regional and national averages. Where we're at now is, as you can see, our the rate of increase in cases has slowed down somewhat, although still going up. It's not going up as fast as it was. We're now above the national rate, but below the regional rate. And then the bottom graph just shows where York is in comparison with the other local authority areas in Yorkshire and Humber. On to the next slide then, thank you. This is a breakdown of the rates of infection we're seeing. So the number of cases we're seeing per 100,000 population, and also the case numbers. So as you can see, we actually have cases of COVID across all age groups. But rather than just giving you the rates, you've got the numbers here so that you can see the numbers are actually quite small in the older age groups. And that probably reflects how successful the COVID vaccination program has been with older age groups. The largest number of cases we're seeing is in the younger age groups, particularly the 15 to 19 age group. And of course, we know that it's only comparatively recently that over 18-year-olds have been eligible for vaccination. So we would hope to see those case numbers starting to come down. Next slide, please. This really shows what's happened with hospital admissions throughout the pandemic. I was hoping there might be somebody here from NHS England or York Hospital who could have updated us on today's figures. These are the most recent figures we have in public health, which are the 13th of July, when, as you can see, there were 15 people in hospital, 2 in ITU with COVID. Those numbers are still much, much lower than we've seen previously in the pandemic, which is, to be celebrated. But as you can see, those numbers are starting to rise. And so we're keeping a close eye on what's happening with those figures. Next slide briefly shows what's happening with COVID deaths. So the bottom line on the graph, the red line, shows the number of COVID deaths we've had since the start of the pandemic. Oh, somebody's helpfully put an update in the chat. 17 inpatients in general and acute beds and 1 in ITU at the moment. So thank you for that update. So as you can see with the red line, we're seeing very, very few deaths from COVID. And in fact, we haven't had any recent COVID deaths. So that's to be celebrated. Going on to the next slide then, just giving the board a picture of what's happening in care homes. So we have 8 care homes in York at the moment with either a staff member or resident with confirmed COVID. Our last outbreak was the 2nd of July. So we're doing very well in York at responding very quickly when we become aware of cases in care homes. And there's a lot of work that goes on in partnership with the care home to make sure that we've got control measures in place, and that system is working very well. And then everyone knows the impact of COVID in school-age children. We're all experiencing difficulties across all of our services at the moment with the numbers of children that are off school, either because they've tested positive or because they're in a bubble as a contact of a positive case, and the impact that's having on our services with parents having to take time off to care for children. So those numbers are continuing to go up. Once school holidays start, we would expect those to go down. Next slide is just a quick overview of how we're doing with the COVID vaccination program across the different ages and population groups. As you can see, we're doing very well, still playing catch up with some of the younger age groups, but again, quite pleasing performance there, and obviously the efforts on vaccination will continue. Next slide just quickly shows where we are by ward across the city. There's a lot of work that's going on, which the Outbreak Management Advisory Board has oversight of in terms of tackling health inequalities. And I would encourage anyone watching who wants to have more information about that to watch the most recent meeting of the Outbreak Management Advisory Board, where that was discussed in some detail. One of the reasons we've got lower uptake at the moment across Fishergate, Guildhall and Hull Road is really because that has a large young people's population, large student population, and who have only recently been able to eligible for vaccination. So that's the reason why the figures are lower in those areas. On to the next slide then, please. This just shows where we are in terms of variance at the moment. So board members will be aware that the big spike of COVID cases that we saw December, January into February was caused by the Alpha variant, the Kent variant. We still have some cases of COVID caused by the Alpha variant, but as you can see, it's the Delta variant that is now dominant, which is the case across most of the country. And then we do monitor other variants. And as you can see, we have one confirmed and one provisional case of the Gamma variant at the moment. Next slide just really is a reminder that we're now in step 4 of the roadmap, or legal restrictions have been lifted. And then the final slide, I just want to say something about the citywide campaign that has been launched. So even though the legal restrictions around COVID may have lifted, as a city across all partners, we're committed to ensuring that York continues to be a COVID safe place for people living, working and visiting in York. And so we're encouraging hand washing, the wearing of face coverings and space, and encouraging everyone into the city to protect each other, to respect and be kind. So members of the board will see much more about that campaign over the coming weeks. So that's a very quick update, Chair, but I'm happy to take any questions.
Just got one question coming from Councillor Looker. Janet, would you like to ask your question?
Yes, I want to pick up on the slightly tricky area of test and trace, contact tracing. We are continually getting all sorts of extraordinary messages from governments, everybody, we are receiving a lot of information that people are taking themselves off the NHS app, that people are ignoring it, and I just wondered if you could update us on how you think within the city we're managing, because everybody agreed right back at the beginning that good contact tracing was one of the arms we had of getting on top of or getting control of the virus. So how are we doing on contact tracing?
We're doing very well with contact tracing in York, although there has been a recent change to government policy around the local partnership working the government is doing with local authorities. So we still very much encourage people to be regularly tested, that we have good access to symptom-free testing in York. So we're still encouraging people to have symptom-free testing regularly. If people then test positive with a symptom-free test, we're strongly encouraging people to then go and have a PCR test. That's a more sensitive test that will confirm the diagnosis of COVID. And the results then of that test are fed in to the national test and trace system. Up until recently, our contact tracing service was then given they had immediate access to that, the details of people that had tested positive, local O as it was called. So we were working in partnership with NHS Test and Trace with a local service to be able to receive that information straight away as soon as a positive case was uploaded onto the system. And then our contact tracing service was also doing the contact tracing of all contacts. So they would contact somebody who tested positive. They would go through with them either on the phone or face to face, if that was necessary, to identify all of their contacts. And our service would have been contacting the contacts. NHS Test and Trace has recently changed their policy around that. So we're now not notified of positive cases until after 4 hours, although there is sometimes delays, so it can sometimes be longer than that before our local contact tracing service gets notified. And we're not allowed to follow up contacts of positive cases anymore. I'm hugely disappointed by this, because we've demonstrated in York that we have an excellent testing and contact tracing system in place that consistently achieves over 90% of contacts, and I'm convinced that has helped to prevent us having any major outbreaks in York. So we are trying to lobby the government around that, to say that, please give it back. There's no real rationale being given for why it's been taken away, other than the fact that NHS Test and Trace will review the situation, and local authorities may get the contact tracing of contacts back later in the year. My argument is, why take it away in the first place when it was working very well? And so we are going to be communicating with the Outbreak Management Advisory Board to test out whether members of the board would be supportive of us sending a letter from York to the Secretary of State to highlight our concerns around this, and to ask that consideration be given to reinstating the local tracing of contacts. There's a question in the chat, Chair, about
yes,
self-isolating. This is
Sharon, it'll have to be very brief or put in the chat, I'm afraid, because we're overrunning. It's about, for those that can't see it.
Yeah, just to
it
say,
is, isn't it? Yes.
To anyone listening who can't access the chat, that on the 16th of August, the government will be changing the legal advice around needing to self-isolate if you're contacted by NHS Test and Trace, if you are, or pinged by the app if you're double vaccinated. So that's due to change anyway on the 16th of August. The government has recognised the massive pressures that being pinged by the app is causing across health and social care. So they have issued guidance around that we are currently working through. For primary care, Emma, we're going for a joined North Yorkshire-York approach. So both CCGs and Directors of Public Health have got a template that we've developed to provide some guidance to primary care on how to implement this, that should be issued shortly. And then obviously the hospital trust is sorting themselves out. As a council, we're working very closely with care homes and other social care settings around how we're going to implement this, so that we do it in a secure way, that we help protect services, but we also make sure that we're not putting patients and care home residents at risk as well. So all of that work is happening behind the scenes, and there'll be further information coming out of that through usual networks shortly.
Thank you, Sharon. It is a very tricky one, as we've seen very recently with ministers, but we won't say any more about that. I want to move on to agenda item 7, which is Sian, and it's again another very interesting report, which is the Healthwatch annual report. Sian, would you like to speak to the report?
Yes, thank you, Chair. And thank you for this opportunity to share our annual report with you and our work plan for the rest of this year ahead. I think I'm not alone here in feeling that this past 17 months has been an extraordinary time, and actually reflecting on that hasn't been an easy task. But what I wanted to pull out was some of the highlights from that very difficult time. I think in page 88 of our report, which is page 4 of our actual report, we've listed many, many thank yous, but actually there are thank yous that should go beyond that. It felt very weird in these strange times to feel like actually we improved our working relationship with a number of agencies and organisations across the city. I should say not least within our own organisation, within York CVS. I think Healthwatch York and York CVS have never had a closer working relationship, and I've really valued that. It's been a benefit of being forced into strange situations. I think we've also seen, though, our improved working relationships with a wide range of partners and belief across the system that we are all trying to do the right things together. And when we get that right, it is much more powerful than when we try and do the right things alone. I think I would also like to mention our evaluation. It was a very slimmed down version this time, deliberately. We didn't actually want to tie up a lot of people who were already involved in pandemic response to question them about their working with us. But from even that slimmed down response, we got some really lovely examples of how our work had supported people that sometimes we're not even aware of until we get this feedback. And so it was great to have those positive examples at a time where life has felt quite tough, but also to have some really good suggestions that can help us to continue to improve as we hopefully continue to move forward out of these strange times. And I also wanted to just flag up some of the things that we are currently working on that will be listed there in our summary work plan for you. We're currently doing work around dementia. That survey is out now. There is a survey for people with dementia, a survey for people living with or caring for someone with dementia. And for anyone who doesn't want to do that, we have a simple one-page feedback form. Tell us anything we don't know about dementia in the city. I think it's really helpful if people get involved with this and tell us everything. All that we hear will feed into the City of York's dementia strategy going forward. So this is a really good opportunity to tell us what is and isn't working. We are also doing work at the moment around dentistry. I don't want to spoil Roger's moment when he lets that report free into the world, but the first part of our work has been engaging with local dental practices to understand what is on offer. And I don't think this is massive spoiler alert, but there isn't any headline news. If you're looking for a dentist, we found one in Wakefield. So good luck, everybody. The next stage of that work will be asking members of the public about their experiences. And I have to say, this has been an incredibly challenging issue for us during the pandemic. We don't have anywhere to signpost people to. We don't have any positive messages of hope. We have been flagging this up through Healthwatch England, and I understand they are looking at this as a national issue. But I do think in terms of our health and care system, in terms of well-being, in terms of the public health impact of not being able to look after your oral health, many people I've spoken to feel powerless about this, and I think we need to think about how we regain some power. And finally, I should say the integrated care system, we've been approached by quite a lot of people who are very interested in it, but really don't understand what's going on. So I think part of our role going forward is to try and help people understand that and to think about what role we can play in making sure what matters to people is what matters to us. So I will stop there, but I will be very grateful for any questions.
Thank you. There's one from Sharon. Sharon, it's going to have to be a short one, I'm afraid.
Yes,
but you're very welcome to ask
it. It will. Thank you for the report, Sean. It was really enjoyable to read. Just a quick comment on access to dental care. The Health and Social Care Policy and Scrutiny Committee has identified access to dental care across all ages as something that they want to look at. It's on the forward plan for scrutiny for January. So I'll make sure that you're linked into that, because all of the work that you've just described, I think, will be very relevant for scrutiny to be aware of that. So I'll make sure that happens.
Yes. Nigel has put in the chat, dental health, very relevant to the first 1,001 days. You're absolutely right. You're born with all your teeth, and people don't believe you when you tell them that. They're all in there. And if you don't get that right, particularly diet in preconception and conception, then you're in trouble. Anyway, we won't go into that. Thank you, Sian. It was an interesting report. And I was amazed you have so few people. And I thought the little stories, the COVID stories, were really good. Really enjoyed reading them. They're very powerful. So the next thing we have is Sharon being very noble, because this is the BCF report, the Better Care Fund. And normally I'm the only one that gets the whole lot, because it normally comes in between meetings. And this is Pippa Corner has done this before she left us for Pastures New. And we are very grateful to her. And that perhaps could be minuted. I don't know if she'll ever see it, but certainly we are. It's a huge piece of work, is the BCF. And we will have another AD starting before too long, Jamila Hussein, who will present the BCF report, but she's not with us yet. So Sharon has been very good and says she will present it. So Sharon, I don't know if you want to talk about it a bit, and then we need to just look at the recommendations at the end. Thank you.
Yes, thank you, Chair. Yes, I'm presenting it, but I'm not sure I'll be able to answer any questions. So we might have to just make a note of those and and
yes, that's
include
fine.
them in the minutes. I mean, really, I'm going to assume that everybody's read the report. Apologies for all of the appendices that were attached, but they were referred to in the report. And so the decision was made that we needed to include all of the appendices. So really, what the board is being asked to do is to note the report and the progress that's being made on the Better Care Fund. As Councillor Runciman has said, there's a lot of work going on, and the report refers to some of that. We need to approve the financial plan. That's the one page at Appendix 4. So we're asked to approve the financial plan for this year. To agree the key recommendation that we need a whole system intermediate care strategy for York. We don't have one at the moment, but the report identifies the need for one. And my suggestion, Chair, is that the board delegate that to something that the Health and Care Alliance and the Health and Care Collaborative could work on to develop that. And then also the other key recommendation is to review the terms of reference of the performance and delivery group of the BCF, to review those terms of reference and membership. But it would seem sensible for the new Assistant Director for Commissioning and Prevention to pick that up as an action. I believe she takes up post on the 13th of August.
Yes, that's absolutely right. Good.
I leave it there, Chair.
I think we've lost you, Sharon, right at the end of that, but I think we've got the point.
That's all I was intending to say. Thank you, Chair.
Right. Okay. So we've got 5 recommendations. Are there any of those recommendations that anybody would query? Doesn't look like it. So I can say that we accept all those recommendations. And now fortuitously we come on to Emma, and you've just been given a job to do, Emma, I think, about the intermediate care strategy for York. So that's very interesting. But if you'd like to give your report, the report of the Health and Care Collaborative, we'd be very interested to hear about it.
No, thank you, Chair. I'm going to keep this really brief. I think one of the key roles for the York Health and Care Collaborative is to make sure we keep feeding into the Health and Wellbeing Board, because obviously we are the multi-agency provider group that are coming together to try and make the most out of the resource that's in health and social care. So it talks about the updates on the main programmes of work, and I guess there's just a couple of things really I wanted to highlight today. So as you'd expect, prevention is a huge part of our agenda. We continue to work alongside many of the work streams. So we're looking at, there is already, as you saw from your diagram, the Tobacco Alliance, but I guess the challenge for York Healthcare Collaborative is to be accountable for those outcomes and to hold the different providers to account. So we work heavily with Peter Roderick on getting that data and showing that things are improving. And I think that's our main challenge, that, are we seeing a reduction in smoking in pregnancy, reduction in smoking in the key rates, and what can we do together by working together to improve that? So I guess we're still working on many of the prevention streams. I know this board will be very interested in the alcohol pilot, so we've touched on that before. We're now in a position where the adverts are out for, this is for the community skill set to try and support patients with the lower level drinking problems. So not dependent drinking, but what we class as hazardous. So drinking called physical harm, but perhaps you don't need to have detox and kind of the whole level of support. And they're interviewing at the moment, and we're hoping for an October, sort of late October, early November start date for that programme. So I think it's very welcomed across the system to have that support. And I say, so I know this was something specifically from the York Health and Wellbeing Board that promoted that. So we're very welcome to have that funding. And it's going to be implemented, I say, the aim is 1st of November. So I hope ourselves and Changing Lives, who are the sponsors for that, will be able to come to the next Health and Wellbeing Board with a more active update. So just to let you know, it's ticking along. We're doing lots of work with the mental health, which is our other largest work stream, and to find out what's going on in the city. There's this big project that was called the Northern Quarter project, looking at good ways of using community-based asset approach to mental health. It's working so well, it's now really adapting across the whole city. So we get regular updates on that, and some additional ICS funding that's coming to support the massive impact of the COVID pandemic on mental health. And then the final the large work stream is about sort of aging well and end of life care. And we've got a bespoke workshop to look at how we improve end of life care and then address this aging well, which is about a community response team for those in need of health and social care within 2 hours. So there's a big program of work again where we're trying to, whilst we get nobody within YHCC holds a budget, but what we do is we come together as a group of providers to look at how we can make the best use of a resource. So we continue to do that. There are many threads. Certainly children welfare is one of our key themes for this year, which is going to be a thread across all the aspects of the work we're doing, and learning disabilities, and so that we ensure that your healthcare collaborative discusses the issues that the Alliance Board identify as being priorities for our area, and hopefully feed back into yourselves at the York Health and Wellbeing Board, say this is what we're doing, we'll be on target. So I think those are the kind of main things to pull out from the report. Lovely.
Significant feedback into Health and Wellbeing Board about our priorities and the JSNA, what that highlights too. And I was mighty impressed by your COVID support hub with over 4,000 people being supported. That is absolutely brilliant, because sometimes people don't need a pill, they just need a person, don't they? And I'm also very pleased to hear about the lower level alcohol support. Yeah.
And then the other one.
Any questions or comments, Gemma?
Sorry, I was just going to say one on that. So the other advantage, the COVID hub, we're so grateful we've managed to kind of scrabble together system money. So it's the commissioners and obviously very expect to keep that hub going, because the other big thing we haven't really talked about at all today is long COVID. So the impact, whilst people are not being hospitalized, we know that COVID is not an illness you want, and it's causing sort of another whole wave of an illness that we need to address. So there's a lot of support going on from the COVID monitoring hub about trying to raise awareness and looking at identification and supporting people with sort of early long COVID symptoms.
Yes, I'd really like something of that to come back to the board, because I think I was talking to somebody about it yesterday at a meeting. Long COVID is just coming to be a real thing in people's minds. I'm not sure it really was before, but it certainly is now. Nigel, you want to comment?
I just want to say thanks, Emma, for that presentation and all the good work. I think what it stresses this is the importance of knowing your community and knowing your neighbourhood. So this is a theme that's gone through us all today, really is about understanding and knowledge of our communities and residents. So I think as we move towards a bigger integrated care system, we have to acknowledge that actually action and understanding needs to be done at place and neighbourhood. And so that's where focus and flow needs to go to. So it's just to stress that and to say thank you.
Yes. Any other comments or questions? No. Thank you, Emma. You've compressed all that very capably. There's such a lot of work going on there. It's admirable. And thank you for it. That's good. Now, I think miraculously we've managed to get to the end of the agenda. Is there anything anybody wants to say before I wrap up? It has been, as usual, a very interesting meeting. I hope, Councillor Looker, you found it interesting too, despite all the paperwork, which always takes a bit of reading, but in my opinion, is well worth it. Okay, thank you very much, everybody, and thank you to all those that have contributed. And I'm sure we should be following up some of the things that have been mentioned today that really need some work on them. And my pet one, of course, is the first 1,001 days. But mental health, we haven't said a lot about mental health tonight, and early mental health help. And I hope that that will be on our agenda very soon, because that is also very, very important as we come out of the pandemic. Right, thank you very much, everyone.